Adverse Events in Seniors Related to Spinal Manipulation, two Medicare beneficiary studies. Of course, it's important to weigh the risks and benefits of any treatment approach. Searching for and finding evidence of each is often difficult, though. For manipulation, many studies have been conducted over the last decade or so, all indicating very little risk of serious adverse events. In fact, so little that they are often the calculation of adding together case reports rather than data from randomized controlled trials or even retrospective studies. Yet even though the rates are extremely low, judgment enters because some concerned medical doctors and researchers have made it their role to determine the value of manipulation for the patient. In other words, regardless of a low risk, is the risk-benefit ratio acceptable? For example, Ernst has published numerous reports about serious adverse events for most forms of alternative medicine with a focus on manipulation. This study from 2007 is representative, entitled Adverse Effects of Spinal Manipulation, a Systematic Review. He found the following adverse events reported: cervical artery dissection, dural tear, nerve injury, disc herniation, hematoma, fracture, and cord injury. Generally, when you use the term systematic review, you expect the synthesis of multiple RCTs or other large studies. Yet these are all case reports or series, so therefore it should be titled a systematic review of cases. And although he found that serious adverse events occurred in as much as 1 per 400,000 to as little as 1 in 2 million manipulations, his personal belief is that the benefits don't justify the risk. There are a couple of reviews published over the last few years that come to similar conclusions, but in contrast to Ernst, don't place a judgment on risk-benefit. Here is one from 2013, an update of a previous Cochrane review. And yet another in 2013 published in JMPT entitled Serious Adverse Events in Spinal Manipulative Therapy of the Low Back Region, a Systematic Review of Cases. In that study, the breakdown by percentage of adverse events was cauda equina 38%, lumbar disc herniation 30%, fracture 9%, hematoma 8%, and all other 15%. Also remember that this still relies on someone's determination of cause and effect, which could very likely be biased. Yet none of these studies have focused on the senior population. The two studies we will now review were generated from extensive Medicare data and are the first to look at specifically manipulation and adverse events in the senior population. The first we will review is entitled Risk of Traumatic Injury Associated with Chiropractic Spinal Manipulation in Medicare Part B Beneficiaries aged 66 through 99, published in JMPT in 2015. Data sources for this study were combined from the following: denominator files for beneficiary demographics, carrier files for outpatient claims, Medicare provider analysis and review files, as well as Medicare physician identification and eligibility record files for physicians' data for the years 2006 through 2008. So who were the patients? Well, they're all beneficiaries covered under Medicare B age 66 through 99 with at least one allowed Medicare B claim in 2007 for an office visit to either a chiropractor or primary care practitioner with an associated ICD-9 diagnosis code for a neuromusculoskeletal problem. Excluded subjects were those with a history or concomitant diagnosis at the index office visit of injury to head, neck, or trunk. However, there was a necessary exclusion exception: ICD codes within the range of 839 through 839.59. These subluxation codes were allowed for the chiropractic visits, even though this represents a vertebral dislocation for MDs in their coding. The total of Medicare beneficiaries was approximately 23 million, but for the criteria of this study, it was necessary to eliminate the following: those seeing both a DC and an MD totaling around 481,000, or a recent history of trauma totaling around 296,000. There were two cohorts. For the chiropractic cohort, there had to be at least one allowed Medicare B claim in 2007 for a chiropractic office visit with spinal manipulation, and CPT codes 98940 through 98942, plus a provider specialty code for chiropractic physicians was identified. For the medical or PCP cohort, at least one allowed Medicare B claim in 2007 for an office visit for an E&M associated with the provider specialty code for family medicine, internal medicine, or general practice. The hazard period for identifying outcomes was 7 days following an office visit for a neuromusculoskeletal problem. Remember that the farther out one is from the actual visit, the more noise occurs, meaning that causes unrelated to the event or natural history can occur, and the longer the period, the more likely this is. Injuries searched for included dislocation and soft tissue injury, fracture, injury to the brain or spinal cord, injury to blood vessels, and injury to nerves. So again, the total number of qualified participants remained around 6 million, and those were broken down into an MD and DC cohort, totaling 5,600,000 for the MD and only around 1 million for the DC cohort. Some results? Within 7 days of an office visit, serious events occurred in 28 per 10,000 in the chiropractic cohort and in 36 per 10,000 in the primary care cohort. The cumulative probability of injury was lower in the chiropractic cohort as compared to the primary care cohort. Adjusting for differences in patient characteristics, risk of injury in the chiropractic cohort was 76% lower compared to the primary care cohort. Of the 2,786 injured subjects in the chiropractic cohort, there were 1,059 dislocation or soft tissue injuries, 1,132 fractures, 562 brain or spinal cord injuries, and 33 blood vessel injuries with no reported nerve injuries. In evaluating the relationship to specific comorbidities, the associated risk of injury occurred with coagulation defects as an elevated likelihood of injury in general. For inflammatory spondylopathy, increased risk for soft tissue injury or dislocation. For osteoporosis, increased risk in general and specifically for fracture. For aortic aneurysm and dissection, an increased risk in general and specifically for fracture and injury to blood vessels. And for the long-term use of anticoagulant therapy, an increased risk for brain or spinal cord injury. Some limitations are that this is, of course, a retrospective study, so we know that cause and effect cannot be identified, only association, and then there are some inherent potential biases given retrospective studies are not randomized. And not all chiropractic manipulation involves the same technique. And the researchers did not use E-codes that describe the circumstances causing an injury, so the study does not reveal iatrogenic injury that may have been the cause. The second Medicare study focuses on the relationship to cervical manipulation and stroke using the same approach of studying Medicare beneficiaries. It's not clear if this is a sub-analysis or a separate study. The title of the study is Risk of Stroke After Chiropractic Spinal Manipulation in Medicare B Beneficiaries Aged 66 to 99 Years with Neck Pain, published ahead of print in JMPT in 2015. Clearly, the authors are using a very similar approach to the landmark Cassidy et al. Study that calculated associated risk comparing visits to either a DC or an MD. To keep statistical comparisons in line with the Cassidy and other studies, the hazard period was 30 days after an office visit for neck pain. Again, using ICD codes, strokes were categorized as vertebral basilar stroke and non-vertebral basilar stroke. VBS was identified by ICD codes 433 through 433.21, and all other stroke codes were categorized as non-vertebral basilar. Because there was an MD and a DC cohort, it's important to compare and call out any differences. The chiropractic cohort was nearly twice as large as the primary care cohort, and the number of chiropractic office visits was more than 11 times greater than that for the primary care cohort. The chiropractic cohort was also generally younger and healthier, and there was a higher proportion of males and significantly lower proportions of blacks and other minorities. Not surprisingly, the specific incidence of VBS was too small to report, so the authors were forced to compare incidence of any type of stroke. This could be a problem and clearly be misleading simply because the primary type of stroke identified in the literature associated with manipulation is vertebral basilar and in rarer cases carotid artery-related stroke. What then is likely to happen is there is going to be a very large overlap between natural history of stroke in these senior patients and coincidental visits to their primary care doctor or chiropractor. So clearly, there is no evidence of a cause and effect relationship to stroke in general for patients seeing an MD or DC, so reporting on this data seems only to provide coincidental information, which serves no apparent purpose. But the results were, for stroke of any type in the chiropractic cohort, 1.2 per 1,000 at 7 days after an office visit for neck pain, and 5.1 per 1,000 at 30 days. And for the primary care cohort, 1.4 per 1,000 at 7 days after an office visit for neck pain, and 2.8 per 1,000 at 30 days. For days 1 through 24, there were 2 strokes in the DC cohort and 7 in the MD cohort. For days 25 through 30, there were 116 strokes in the DC cohort and 115 in the MD cohort. Specifically, the highest day of risk occurred at day 25. However, this occurrence does not seem to provide any time relationship to any identifiable cause and effect relationship, so has little meaning. So now what needs to occur to make sense of this is to compare stroke rates for all Medicare beneficiaries to get a sense of whether the incidence is higher in those seeing a chiropractor. Well, coincidentally, a recent report summarizes stroke rates over a 20-year period overlapping with the previous study's time frame. It's titled Trends in Stroke Rates, Risk, and Outcomes in the United States, 1988 to 2008. They found that stroke represents 20% of Medicare claims, and that a prior diagnosis of TIA was found in 7.1% with ischemic stroke and 4.7% with hemorrhagic stroke. As usual, ischemic stroke is far more common than hemorrhagic stroke. They found a trend of declining stroke rates. So for those over 65, there was about a 40% decrease over 2 decades. However, what we find in comparing the data from this study and the previous one on stroke and chiropractic care in Medicare beneficiaries is that they do not measure the same thing, which makes comparison next to impossible. In the manipulation study, there was a hazard period of 30 days, which means after an initial visit, the patient was followed only for 30 days. It's not as simple as adding the strokes in the DC and MD cohorts and multiplying by 12 for 1 year. The only way comparison could be made is to have a total of all strokes in a given year period for the chiropractic patients and subtract that from the total in the stroke trend study. So for example, if there were around 1,000 strokes total, and let's say 600 were found in those who sought chiropractic care, perhaps an alarm would sound for the possible increase in ratio compared to the MD remainder. But it was not evident in the manipulation study that they collected the DC-specific annual stroke data. If they had, a comparison would then be possible. One thing we do know from this study is that vertebral basilar stroke was as rare as reported in most previous studies, at 9.8 per million Medicare beneficiaries with an office visit for neck pain to either a DC or an MD. Consistent with other broader-based studies involving the general population, including the young and old, risk of serious adverse events following manipulation is extremely rare, and when compared to visits to MDs, quite similar, indicating that there is nothing in the treatment approach that chiropractors use in general that could be associated with a specific concern for risk in senior patients.